Thank you, ma'am and sir, for that kind introduction. And at the outset, I want to thank Dr. Sapnil and Dr. Sujit for inviting me in this August gathering. So, my title is Think Broad and Lessons Learned from the GI tract and hepatobiliary tumors. And I have picked up 4 cases from the last 2 months reporting where I really learned something. So I'll start with the case 1. This is a 53-year-old male patient presented with abdominal pain of 4-month duration, and that was aggravating on fasting but relieved on taking foods. No other comorbidity, no past history, no family history. Patient was a smoker and drinker, but that stopped long ago. On CCT, there is an asymmetrical thickening in the lesser curvature with nodular extension into the perigastric fat, and multiple perigastric nodes were there. And on CT, FDR avid lesions extending from the cardia along the lesser curvature. So it is a long ulcerating lesion. But we received 1 block for review containing multiple biopsies from the lesion. So this was the lesion, very cellular tumor, and on the surface we could see multiple papillae, and underneath there was a solid sheet-like appearance, and it was quite prominent clearing that we can see in this low power itself. So these are the areas of papillae, but as commonly we have seen papillary tumors if you see the WHO classification of gastric tumors, it is not resembling the papillary carcinoma of the garden variety. As well as if you see the invasive component, we cannot say it is tubular, it is not so conventional, as well as this is not even we can call it a poorly cohesive or signet ring type. But clearing was very prominent, and on closer look we could see there are 2 areas. You can see these polygonal shaped cells in between, so we thought this could be hepatoid cells, and these are the high power. We are seeing cleared cells with cytoplasmic clearing, as well as there is vacuolations in the cytoplasm. So these are the papillae we can see. This is not at all classical foveolar epithelium what we commonly see. There is stratification and there is nuclear vacuolation both in the supranuclear region as well as subnuclear, almost looking like endometrial carcinoma. And this is further higher power. You can see supra and subnuclear vacuolations and stratification, and this is what we can say this is possibly the foveolar differentiation and foveolar epithelium. And these are the areas of clear cells, quite solid sheet-like appearance. The cells are quite bubbly and clear. And in addition, in the adjacent area, what we could identify that the tumor was also showing lot of polymorphs. So that was quite, these cells were staring at me, and in addition there are many Russell bodies inside as well as in the adjacent area in the stomach. And I could also see some entrapped foveoli in between. So this is what I found. I thought this is a gastric adenocarcinoma, but what is the type? We saw this type of epithelium with vacuolations, clear cells as well as hepatoid cells. So if we look into the WHO classification, as I have already mentioned, we cannot exactly classify according to WHO classification, but there is some resemblance with the clear cell adenocarcinoma and as well as hepatoid adenocarcinoma, which usually are positive for the SAL4. So we started, to start with, we did the alpha-fetoprotein stain, and the tumor was positive. Both the cells as well as surface cells were positive for alpha-fetoprotein. So if we look into the alpha-fetoprotein positive hepatoid carcinomas, they can be of 3 types. One is hepatoid. This is the classical hepatoid type, diffuse area you will see. But in this case, we saw only few cells with hepatoid differentiation, and these cells should be positive for at least 1 marker of hepatoid differentiation. In this case, AFP was positive. This is the fiscal gastrointestinal type. The cellular differentiation would be just like what I showed, those endometrial type, and you will see marked supra and subnuclear vacuolation, what was present in this case. And in this case, to diagnose it, we should see at least positivity for 2 markers, alpha-fetoprotein, SAL4 and glypican 3. along with albumin can show some hepatoid areas. And there is another differentiation what is described, that is yolk sac-like tumor. Here you will see at least 2 marker positive out of these 3. And most of these tumors have been described extremely rare, but have been described in the stomach, very rarely in the gallbladder, and as well as extremely rare in the pancreas as well as colon. So I went ahead to, for doing SAL4, and as has been highlighted in the previous talks also, it is a marker of the primitive differentiation or embryonal differentiation. And you can see both the papillary areas as well as the solid sheet-like areas are SAL4 positive. If you do SAL4 in adult stomach, the mucosa will be negative. However, if you do SAL4 in a fetal stomach of around 9 week or 10 week, it will be, the epithelium will be positive. This is the MARC5AC. You can see I showed also very focally there was foveolar differentiation. Predominantly the tumor cells were negative for MARC5AC. The tumor cells were also positive for glypican-3 and arginase 1. So what we have, I diagnosed it as a AFP producing gastric carcinoma with fetal enteroblastic as well as focal hepatocyte differentiation. Now, if we look at the TCGA database, most of the gastric carcinomas which shows the high serum alpha-fetoprotein level, 70% of them will show you this type of fetal differentiation, that endometrial type of appearance. Only 5% tumors with low AFP can show you that type of appearance. So that appearance you should remember. And most importantly, why you should identify this, because both univariate and multivariate analysis in previous studies, though the number is very small, it shows that the prognosis is very poor and 5-year disease-free survival is only 20%. Many other embryonic stem cell markers can be positive along with SAL4 like OCT4. And most of these tumors, if you see, they are HIF, you will see abnormality of the HIF pathway abnormality as well as abnormality of the stem cell, the pathways which are basically regulating the embryonal stem cells. In addition, P53 mutation is quite common. They are uniformly EBV-ish negative and they are always MMR proficient. So we went ahead by doing P53 staining. We did not do P53 mutation in this case. However, the staining came positive diffusely. HER2/neu was negative and the tumor was MMR proficient. If you look at the series S, you will find that this type of primitive differentiation, like in this study, this was from I think China, and they studied 302 early gastric carcinomas. They reviewed all and did all these markers. They found that below less than 10% of the tumors show this embryonal differentiation, and histology they said it is like conventional carcinoma. There is one rare example where these authors identified a carcinosarcoma-like tumor with focal embryonic differentiation. So we can see this type of embryonic differentiation in this type of primitive tumors also. This is another example from a 47-year-old female gallbladder mass. You can see again we are seeing papillary tumor. The cells are very primitive looking, and at areas there was diffuse clear cells, and these are the cells focally showing intestinal type of differentiation. But please note, in the adjacent area I again saw Russell bodies. Nowadays there is the NTD Russell body gastritis. So it all depends on how the biopsy has been taken. So something calling before Russell body gastritis, as we are seeing Russell body can be seen in this type of tumor association. So we should also talk to the clinicians and see if the biopsy is has been properly taken or not. In this case, you can see in these areas CK20 is positive, but SAL4 is diffusely positive and CDX2 is positive. And Ki67 is very high. This tumor in the gallbladder was also positive for MARC5AC. So I diagnosed this as gallbladder carcinoma with again fetal enteroblastic and focal hepatoid differentiation. So what is the learning point in this case 1? AP producing hepatoid gastric carcinoma and fecal type of gastrointestinal carcinoma are very rare. We have nearly about 35 cases what was reported. They have distinct morphology, immunophenotype, genotype and behavior. The behavior outcome is very poor. That's why histological identification is very much needed. It is not yet a part of the WHO classification of gastric tumors, and polymorphs and Russell bodies are possibly a part of this tumor. There are very few case reports, but in both the cases I identified this, and they are usually, though the treatment experience is limited, they usually are resistant to FOLFOX and the conventional chemotherapies. I'll go to the case 2. This is of 25-year-old female who presented with the left upper quadrant pain and lower GIT bleed. There was also obstruction, and on colonoscopy there was ulcerative proliferative growth at the splenic flexure. And CCT showed a polypoidal growth, and also there was a colocolic intersusception. So this is the radiology. You can see at the splenic flexure there is a large polypoidal growth. USG also showed there is a polypoidal growth, and it shows that it is infiltrating the wall, and there is also intersusception is present. And this is the gross of the tumor. You can see a large part of the tumor is actually polypoidal, projecting into the lumen. But the predominant part of the tumor is going transmurally, and it is infiltrating adjacent serosa and fat. So it is highly aggressive in this gross appearance. This is the tumor which was closely related with the muscle layer. However, focally it was infiltrating the submucosa, and overlying mucosa was not showing any dysplastic change. On closer look, the tumor was comprised of spindle cells, and there were some epithelioid cells and sprinkled lymphocytes. So these are the epithelioid areas which showed prominent nesting pattern, or we can call it a pseudo-alveolar pattern. So these are the epithelioid areas with pseudo-alveolar arrangement. Again, pseudo-alveolar arrangement with some lymphocytic infiltrate. On closer look, the tumor was very pleomorphic, multinucleated cells were there, and cytoplasm was quite rhabdoid at areas and mitotically active. There are lymph node metastasis and lymphovascular emboli. So gross as well as histological feature shows that it is a quite aggressive tumor. So these were my differential diagnosis. It is a gastrointestinal stromal tumor because of the site and closely related with the muscle with rhabdoid differentiation, because we can see this differentiation in GIST also. Rare, but alveolar short part sarcoma I kept as a differential because of the pseudoalveolar arrangement. Clear cell like soft tissue tumor of the GI tract can show this type of appearance. Very rarely PCOMA can show. Colonic carcinoma with rhabdoid differentiation always we should not forget. And metastatic carcinoma we should keep in differential diagnosis of any of such tumors, like urothelial and pancreatic carcinomas can show rhabdoid differentiation. However, CD117 and DOG1 stains were negative, and both keratin and EMA stains were positive, and also the cells were patchily positive for vimentin. So we thought that the tumor has some epithelial differentiation. SMA was negative, myogenin very focally positive, desmin were positive on those rhabdoid cells, CD34 was negative. ACE100 was negative, HMB45 negative, clear cell like soft tissue tumor of the GI tract was ruled out. Synaptophysin and chromogranin were negative, and this is the TFE3 stain, and this is the clone what I used for the first time because we kept a possibility of alveolar short part sarcoma, and it came diffusely positive. So based on this, we could rule out some tumors. Now the possibility based on this positivity, alveolar short part sarcoma was still there. However, as the EMA and other keratin was positive, we also kept a possibility alive. This colon carcinoma with rhabdoid differentiation, we still kept considering. And for the same reason, we did another TFE3 stain with a clone of BioSB, and that came negative. So these IHC markers, we should be very careful. It can show some fidelity because the clone to clone, it can vary. This is the TFE3 Baker-Part fish probe, and you can see there was no translocation identified. And being a very poorly differentiated tumor, you are seeing from the morning INI and BRG we performed, and this tumor, these are all lymphocytes and endothelial cells. INI are positive, but the tumor cells are INI negative. On the other hand, BRG1 stain was retained. So what was the diagnosis based on these findings? It is INI deficient, poorly differentiated carcinoma colon with rhabdoid differentiation. This is about the SNF complex tumors. Why it is important? Because these are the complex which are important for the chromatin remodeling. There are many members, but commonly we do INI1 and BRG stains, and there are few members against which we have nowadays targeted therapy. The immune checkpoint inhibitors can be given. So this group of tumors has to be identified, and any poorly differentiated tumor, we should consider doing INI and BRG at least. Now look at the prognosis of these tumors. All these tumors have been described mostly, this is also very rare tumor, mostly in the elderly patients. Outcome is very poor. Some patients only lived up to 4 years, and there are metastasis, and INI was done in some cases where they could identify both retention as well as loss. So overall 3-month prognosis in this type of tumor is also very poor, 20% only. This is the molecular phenotype. Most of these tumors with rhabdoid differentiation are always microsatellite proficient. However, they show BRAF V600E hotspot mutation as well as KRAS mutation. In some cases, it has been described. So we went ahead by doing these genetic markers or mutation analysis. We found KRAS mutation and V600E hotspot mutation in the BRAF gene, but NRAS mutation was not seen. So based on that, we found that this tumor have a serrated phenotype. Normally we know serrated pathway carcinogenesis in the colon, that shows either serrated carcinoma or interval carcinoma. Nowadays we are understanding that there is a third phenotype where we can see poorly differentiated colonic carcinoma, which are usually INI deficient, which can have a serrated phenotype. And this tumor also were MMR proficient. This is another example. Similar case, 66 female gallbladder mass, papillary and solid areas, and again see this type of pseudoalveolar arrangement. Similar cells, very pleomorphic with rhabdoid differentiation, mitotically active. Always you can do a pass with diastase to see if there is any crystal, because ASPS will come in a differential diagnosis. This tumor, in comparison to the what we have just discussed, this tumor was INI retention was there, that was not lost. So INI may not be lost in all cases. This is also an example of poorly differentiated carcinoma gallbladder with rhabdoid differentiation. And as I've already highlighted, that not always INI and BRG can be lost. There are other proteins or members. There are 29 genes in this complex. Any one can be mutated and the protein can be lost. See this example where BRM deficient undifferentiated carcinoma with rhabdoid differentiation has been described. In the index patient, the prognosis is very poor, as we have told. Gemcitabine and oxaliplatin therapy was given. After 3 cycles, there was no response, and the patient is in terminal stage. I just asked day before, and the patient is further not willing to undergo any further second-line chemotherapy. So what is the learning point in case 2? Poorly differentiated carcinoma of the colon with rhabdoid differentiation, it represents a group of SUI SNF mediated tumors, and they are usually MMR stable and show serrated phenotype, what we are understanding day by day, and deserves histological identification because of the causes I have already told. They are often resistant to the conventional chemotherapy, the prognosis is poor, and treatment, again, our experience is very limited. This is a simpler case, case 3. 54 male presented with a retropharyngeal mass, and it was referred to the GI tract reporting because of the reason I will tell now. There was a difficulty in swelling of 4 months of origin, immunocompetent patient, no other definite lesion, core biopsy for the tumor characterization. The radiologist said there is a tumor, no doubt. So this is the tumor. we can see it is very hypocellular, more collagenized, some inflammatory cells, no definite fascicular arrangement. More pictures, we are seeing the tumor is very hypocellular, no definite fascicular appearance, some inflammatory cells here and there, no mitosis, some eosinophils we could identify. So we were in a fix. If we are seeing a real tumor, these are the eosinophils, there was even not perivascular onion skinning. So we kept a differential diagnosis because we need to characterize the tumor. We thought it is a hypocellular variant of IMT. Because all of us know there can be either nodular fasciitis-like variant or hypercellular variant or hypocellular. We thought that is the closest match, or it can be a desmoid type fibromatosis. We thought, though there was no perivascular arrangement, we still thought, can it be an inflammatory fibroid polyp or an inflammatory fibrous reaction? We did SMA stain, very few cells were positive, CD34 was negative, so inflammatory fibroid polyp you can rule out. Beta-catenin is negative, a desmoid type of fibromatosis you can rule out. ALK1, though it can be negative even in IMT, it did not support our differentials. So we are still with some differential if it is IMT or it is an inflammatory reaction to the inflammation. When we discussed with our clinicians, they go ahead with the second biopsy. It is a repeat biopsy, similar pattern, again inflammatory cells. It is from the other area, other pole of the tumor. Similar pattern, no fascicular arrangement. However, luckily what we identified in this case is that few granulomas and giant cells were there within this tumor, you can say. And on higher look, we could identify these are the fungal bodies. And on pass and diastase stain, we could identify septate fungal bodies, and there are also right angle branching. So by this time, we know that this is actually benign fibroblastic pseudotumor in reaction to aspergillosis, extremely rare presentation. These are the case reports. These two are 14-year-old male patient, both 14-year-old, and both responded very well to the antifungal therapy. One presented with the proptosis of the right eye. This is an intracranial tumor. Both are immunocompetent. This is a 56-year male patient. Again, this was a diabetic patient, again CNS aspergilloma, and this is a 27-year female, pregnant female who presented with respiratory distress, and there was a aspergilloma associated soft tissue mass. There are more examples. So what I want to say that very rarely we can get this type of example where we are really pressed to, and radiologists say this is a tumor, and clinician also said this is the tumor, just tell us the type of the tumor, you will see this type of presentation. And we found that there are few variants of aspergillus like flavus, fumigatus and niger who can present as soft tissue mass. I showed you some examples. In core needle biopsies, if typical cell culture like appearance and fascicular arrangements are not there, we should always keep in differential diagnosis an inflammation related fibroblastic proliferation, and aspergilloma associated soft tissue mass especially are common in the head and neck. You have seen so many examples. Few examples were in leg, but that was extremely rare, and timely diagnosis and treatment can show excellent prognosis. Can I go ahead with the last case? Yeah. 2 minutes. So this is the case 4. Again, you can ask me why this came to the GI reporting. You will understand why I'll go through. This is a 53-year-old female, old operated uterine tumor, and you can see that attached report, outside report said that this is an endometrial stromal tumor. The patient already received 4 cycles of adjuvant therapy. We don't know about detail. There was a right abdominal wall mass. You can see there is a mass which is presenting there for 5 months, and FNA was tried outside, and that reported as fat necrosis. And again, we got 2 blocks. Being a referral center, we get many review cases. And these are the core biopsies under review. You can see this is a cellular tumor with some pale areas in between. And the cells are really, again, epithelioid to polygonal with some stroma in between. And the nuclei are widely apart. That means they have eosinophilic cytoplasm also. This is the higher look. You can see some conspicuous nucleoli. These are the eosinophils, eosinophilic cytoplasm, and focally that was bubbly and cleared also. And there are so many mitotic activity. So this is the epithelioid tumor, no doubt. We gave differential diagnosis. Can it be epithelioid leiomyosarcoma, epithelioid cyst? It may be unrelated to the primary tumor, obviously. And clear cell sarcoma-like tumor of the GI tract can show this type of appearance also. Epithelioid MPNST we kept as a possibility, and though it is not looking like, because of the outside report mentioned, we still kept a differential of low-grade endometrial stromal sarcoma. The tumor came positive both for SMA and desmin. However, the tumor was diffusely positive for DOG1 and negative for CD117. We thought this case is solved, but DOG1 is positive. Again, we are fixed. CD10 was negative, so endometrial stromal tumor was not considered. Being undifferentiated, it is not exactly undifferentiated. We still did INI1, which was retained. S100 stain was negative. Keratin was negative. Vimentin negative. Because we considered clear cell tumor, HMB45 we did negative. And S100 was also negative, I mentioned. My D1 was also negative. Now, we still have differential of either it is epithelioid leiomyosarcoma or epithelioid cyst because of morphology and this type of overlapping IHC. If we talk about the classical teaching, in a cyst, desmin comes very rarely positive, okay? If you see a cyst which is desmin positive, that too diffusely, you should think of some special scenarios like the cyst can be epithelioid in morphology like our tumor, or if the cyst is of esophageal in origin, okay? In this case, it can show cyst desmin positivity. On the other hand, CD117 negative cyst can be seen if there is a previous treatment with tyrosine kinase inhibitor. Tyrosine kinase inhibitor therapy, we don't know what was the treatment detail in this patient. There was only history of operated uterine tumor. That can also make your tumor to differentiate from spindle to epithelioid morphology. There can be other rhabdosarcomatous differentiation, and they often show loss of KIT expression. DOG1 we know is more sensitive than KIT, especially in some scenario like cyst of gastric origin. If the cyst of epithelioid in morphology, then DOG1 is more sensitive than the your CD117, and if there is a PDGFR mutation, then also DOG1 is more sensitive. On the other hand, DOG1 positive leiomyosarcoma, actually this is my first experience. I searched in the literature because of this dilemma, and I found that many other tumors can be positive for DOG1, like obviously we are using DOG1 because I knew it is 100% positive and I use it for diagnosis also in Spain. However, renal oncocytomas, chromophobe tumors can be positive for DOG1, and see here, the leiomyomas 10% can be positive, and this is the collated data from various articles. Leiomyosarcoma, the range can be 4 to 27%. That can be either patchy or diffuse positivity, and more importantly, please see, CD117 can also come positive in uterine leiomyosarcoma. So it is, so if you just base your diagnosis on CD117 and DOG1, even you can misdiagnose a leiomyosarcoma as a cyst. So we were juggling with this two diagnoses, either it is a desmin positive cyst or DOG1 positive epithelioid leiomyosarcoma. We talked with the clinician and they were so generous, they asked the patient to submit 2 more blocks, just 2 more blocks. And see this, these are the skeletal muscle, this is the original tumor, okay? And this tumor showed the similar morphology, and that was not at all possibly because I saw only 2 blocks. It was infiltrating the skeletal muscle, adjacent area, pelvic muscle, and it showed similar morphology clear to eosinophilic cytoplasm, epithelioid morphology, but at areas there was classical leiomyosarcomatous areas also, and these are the areas of necrosis with epithelioid appearance, and this is the leiomyosarcoma-like appearance which I found. It is classical, and SMA and desmin again positive, similar pattern. DOG1, this time it was patchy positive, not diffuse like the previous one, and CD117 is again negative. Ki67 was 15%. So I preferred a possibility of this is a DOG positive epithelioid leiomyosarcoma over the cyst. This was preferred. However, a mutation analysis in such case could have been more helpful or substantiate my diagnosis. In this case, I could not do that. How that can help? In 85% cases, as we know, the GIST or PDGFR mutations are there. So if you identify in such a scenario these mutations, which will be present in 85% of case, they can substantiate your diagnosis. In this case, it should be, no mutation should be present. However, 15% cases, these mutations can be absent, and they are called wild type of GIST. This can be the scenario in this case. Either it is SDHB deficient, or there are other genes like RAS gene, BRAF mutation, or NF1 mutated GIST. You can see this type of appearance. We also did one SDHB stain, and it show diffuse granular positivity throughout the tumor. So what is the learning point from the case 4? The index case highlighted a diagnostic dilemma which can arise due to marker infidelity as well as lack of supporting clinical information. If the previous tumor was misdiagnosed as endometrial stromal tumor, that may have caused all this problem, and the patient, obviously, the chemotherapy was not proper. Uterine GIST is extremely rare. Please remember, GIST can also arise in the uterus. So, not only if you base your diagnosis on CD117 and DOG, you may commit some mistake differentiating between a leiomyosarcoma and GIST of uterine origin. And uterine leiomyosarcoma, I have already highlighted, in 1/4 of the cases can show this type of expression, and DOG1 is no longer GIST specific marker. There is a very nice article which showed that even if you do DOG in many other GI tract tumors, it can come positive in epithelial, esophageal tumor, gastric carcinomas also. Okay, so we have to be more careful now onwards, and index case highlights the need for mutational study, which could not be done in this particular case. So this 4 case taught me many things, and I thought and I learned to think broad before making a diagnosis, and I think I could convey something or give you a take-home message, and thank you so much for giving me this opportunity.